I want to go through a couple of cases, and then I want to showcase how QFR is going to change your clinical practice in the cath lab flow. So this is my disclosure. So let me show how actually QFR works. So for QFR analysis, you need two orthogonal views of the angiogram, and then in this particular case, diffuse LAD disease. And then software automatically detects the end diastolic frame, and after that, you're going to teach software which point of two angiogram corresponds each other. And then also you're going to tell where is the lesion of interest. And then software automatically tracks the outer curvature of the lumen. And then three-dimensional modeling will be done automatically again. And then what you get is a QFR 0.54 in this particular case, which you need to remember that the QFR is calibrated against FFR. So 0.80 is a cutoff, and then this is clearly significant. And then an interesting feature of the QFR software is that if you see the bottom, that is going to tell you lesion 1, lesion 2, and so on and so forth. And then how many millimeter of stents you put, and then what the expected QFR post-PCI. So in this particular case, if you put the long stent, 48 millimeter stents, then you're gonna get almost perfect QFR results. So let me go to the case one. This is a 70-year-old gentleman with multiple risk factors and history of LAD STEMI several years ago. Now new chest pain, positive stress test, and referred to us for the Cath. And then we shoot the right is clearly high-grade stenosis, and the PCI done, but residual circumflex disease. So this is the earlier case of our institution. So we kind of blindly do, we are in the cath lab doing RFR, QFR, and outside somebody's doing QFR at the same time. And then when we are struggling to engage the guide from a little bit tortuous right radial artery approach, actually I would say my fellow is struggling, and then the outside people already know the QFR number, which was 0.82, and then again it's negative for ischemia. Then finally we got the guiding, we did the RFR, 0.94, and obviously I want to compare to the FFR, and then we did a hyperemic assessment, which is 0.84, which clearly took us probably 10 more minutes than QFR assessment. And if you think about changing clinical practice, obviously fractional flow resolve established as a gold standard in the cath lab. So how you do FFR is obviously you need to put the guide first and a physiology wire down. And obviously you need to give additional heparin, measure ACT, contrast, additional radiation, and then finally you give adenosine to induce hyperemia. But I don't think many people are using FFR, to be honest, anymore, because now we have resting indices. So what the resting indices achieve is by using specialized software, essentially they eliminate the adenosine by just looking at the specific phase of diastole. But now we have QFR. QFR essentially eliminates every step by using AI-based imaging software. So that's why, as Dr. Shah already showed, that the time of procedure can be quite shorter than FFR assessment. And obviously radiation dose should be reduced. So the key point from this particular case is QFR analysis eliminates multiple steps and really streamline physiologic assessment in the cath lab. And QFR can be quicker than wire-based physiology, and then reduction of radiation contrast will be achieved. So let me go to case 2. This is 49-year-old gentleman with hypertension DM-CKD. He presented with inferior STEMI on Saturday, and then right coronary artery was successfully recateterized. But at the time, patient has lots of clot. We have trouble, bringing penumbra, so on and so forth. So my crew is pretty much exhausted at that point. But we know residual disease in ramus existed. But who want to do, put the guide in the left coronary artery after the STEMI treatment and then do physiologic assessment Saturday or midnight case? So what we have done is actually you can do analysis of QFR retrospectively, let's say Monday daytime. Or actually I don't have to do it myself. So then, for example, let's say you can ask your staff or fellows who are trained to do this analysis, or you can suddenly ask my fellow, hey, I have a presentation in TCT next week. Can you do the analysis so that I can use for the presentation? And then as Dr. Shah already showed that in the FIRE trial, actually 1/3 of the patients who get the physiologic assessment in the STEMI setting are done by QFR. So this is striking to me how European colleagues are very quickly changing their clinical practice. So why not in the United States? So key points from this particular case, QFR can be done retrospectively. You don't have to do it by yourself. So clearly you don't need to do physiologic assessment at midnight or Saturday daytime. So let me go to case 3. This is a 51-year-old gentleman with previous right coronary artery STEMI status post PCI from several years ago. Now he has new angina symptom and equivocal stress test results and referred to us. And unfortunately, angio showed mild moderate disease in all 3 vessels, which is a little bit dilemma because I kind of wonder this equivocal stress testing results may be coming from a balanced ischemia. Then I have to prove my referral cardiologist, okay, that needs to be fixed or not at all. Then, rather than putting the wire into all 3 vessels, what I have done is the QFR. In this particular case, LAD QFR 0.97, which is clearly negative. And circumflex was 0.87. Again, it was clearly negative. And then one last vessel's right coronary artery is again negative for ischemia. QFR was 0.99. Now, this is particularly important if you are dealing with 3-vessel disease population. This is the data we published FAME 3 last year. As you know, we randomized 1,500 patients with 3-vessel coronary artery disease, randomized to CABG versus FFR-guided PCI. And this is non-inferiority design, but unfortunately, we could not show the non-inferiority of PCI in 3-vessel disease population against CABG. But when we look at the granular data, and we published this data in JACC intervention last month, what we saw is compared to anatomical syntax score, about 2,000 patients included in randomizing the PCI was a high syntax score. But when we integrated FFR information, lots of patients actually reclassified to low functional syntax score. Similarly, in angiographically speaking, all patients are basically 3-vessel disease population. But when we integrate physiologic assessment, lots of patients, about 1/3 of patients are actually not functionally 3-vessel disease, such as my patient. This is a little extreme example. And then when we follow up the clinical outcome up to 1 year, the red line is the CABG arm. And the blue solid line, this is the low functional syntax score. And then this right-sided panel, this solid blue line is again the patient who doesn't really have 3-vessel functionally significant disease. Those patients do similarly in terms of outcome at 1 year. So then the key point from this particular case is QFR can be used to re-stratify patients with multivessel disease, especially 3-vessel disease patients you have on the table, and you can reclassify with a simple manner to, oh, it's actually this is 2-vessel disease or 1-vessel disease. And you don't really need to send the patient to CABG because you can achieve the similar outcome compared to CABG in the Cath lab, and then you may go ahead and do PCI. So let me go to case 4. This is the patient who got the diffuse LAD disease, and FFR before PCI was 0.75. And then QFR was done in this particular case, which is 0.76, which is very close. And as we discussed a little earlier, that all these information kind of guides you to where to put the stents. And in this particular case, what the software is suggesting, if you put the 30mm stent, which is going to improve QFR from 0.76 to 0.94. So that's what the operator did, and the FFR post-PCI improved to 0.94, which is confirmed by actually doing FFR. So what's the key points of this case? So QFR clearly can help you plan your PCI strategy, and then that can predict post-PCI FFR. Lots of data about this. And for example, you have, let's say, LAD diffuse disease by QFR and diffuse pressure drop pattern. And then let's say this is the only LAD disease, and software is suggesting you need to put the 70mm stent. Rather than putting a 70mm stent, you may want to refer the patient to just medical management, anti-angina therapy to begin with. Or let's say different scenario, diffuse disease in the LAD, you need to put a long stent, and also patient has significant disease in circumflex, the right coronary artery, so on and so forth. Then you may consider patients sending to CABG and the Lima LAD. Obviously, those are good indication for the Lima LAD, diffuse disease. And then do I think QFR should be done for all cases? Which is clearly no, because we purely based on angiographic assessment, so which is garbage in, garbage out. So first and foremost, you need to get the high quality, crisp angiogram, and then I honestly need to adjust my approach to take angiogram, a little more careful about angiographic views, so on and so forth. And obviously, osteo lesion is a little bit of exclusion for, you need to exclude osteo lesion assessment of the QFR, and obviously you have lots of overlap, you cannot rely on the assessment. And unfortunately, if you want, you can manipulate the data. For example, if you want to make the lesion a little look tighter, a little look milder, you can actually do it on the software. So then you need to go through all the training, and you need to discipline yourself so that you won't manipulate these data. And then what I think is going to happen in the future cath lab flow. This is the paper we published last year. First of all, we're going to do coronary angiogram in the cath lab. And if there's any epicardial disease, we'll go ahead and perform angiography-based FFR assessment. And then if angiography-based FFR is significant, you will probably go ahead and do imaging-guided PCI. And post-PCI, nowadays, this is the focus of optimization of a physiologic outcome. And then you can repeat QFR, or nowadays we will probably have IVUS-based FFR and OCT-based FFR down the road. And then let's say your angiography-based FFR was not significant, or no epicardial disease to begin with by angiogram. You can go ahead and perform angiography-based IMR, which is the microvascular assessment you can do with the Medis QFR software. By the way, you cannot do with all the angio-based FFR system. Medis QFR system actually supports the IMR assessment, which is a unique aspect. And then if there's any microvascular dysfunction, you're going to go send the patient for microvascular dysfunction assessment. But if there is no microvascular disease, you may send the patient for standard of care, including maybe you're going to consider acetylcholine testing, so on and so forth. So to summarize my talk, QFR is really a well-validated angio-FFR system with multiple applications in various clinical scenarios. And then potential future application to microvascular disease, which is not approved by FDA yet, but will be soon. And then those details will be discussed by next speaker, Dr. Trevor. And in my sense is these systems will likely replace wire-based FFR system in 80 to 90% of cases. Thank you for your attention.